good morning, good afternoon, good evening to wherever you are in the world. This is episode number 11 of CARPL's Unboxing AI webinar series. Thank you so much for joining. I can still see people trickling in. Thank you for taking the time. And a huge thank you to Dr. Leonardo Bittencourt, aka Leo, for joining us today. But before we go into our conversation with Leo, for those of you who don't know, CARPL is this new software in the CMIO's stack. We are now being called a medical imaging AI platform, and which is, I guess, much better than being called an AI marketplace. But yeah, so that's what CARPL is. We help you build, test, deploy, and monitor any kind of radiology AI in your clinical workflows, and essentially creating what we are calling super radiologists. And super radiologists are radiologists like Leo, who are one day going to be 5x, 10x more productive using, tens or hundreds of AI applications and, banging through cases all day long. So Leo, welcome to the Unboxing AI webinar.
Thank you so much, Vidur and friends from CARPL, for this kind invitation. A minor disclaimer, like I said to you before, I just tested positive for COVID, so I'm subject to interruptions from minor coughing or runny nose, but otherwise I'll be fine.
So we have, to all the attendees, we have committed to Leo that we will try not to make him laugh too hard, because every time he laughs, he coughs. So we'll see how that goes. So Leo, we generally start, I'll maybe give a quick intro of yours. I'll, take that liberty, and then we could dive into the conversation. Also, to all the attendees, feel free to ask us questions. We will prioritize questions over everything else. You can use the chat, you can use the Q&A, you can WhatsApp me, whatever. Maybe the very easiest way for you to communicate. So don't hesitate. So Leo is one of those people who has known CARPL from before we even thought that one day we would be CARPL. So I first time met Leo when he has told me he was going through personally a difficult time. I did not know that, but in, I think it was April of 2019.
It was 2018.
2018, yes, it was April of 2018. Wow, more than 6 years ago, when we were all still young. So I met Leo in Rio, and I was blown away by I think it was a lot of mutual respect that had happened at that time. We were blown away by how one imaging center can have 11 MRIs. That was the first thing that blew us blew us over. This was CDPI in Rio, where Leonardo used to work, and then we had a fantastic discussion about AI, especially prostate MR, and since then, our friendship has bloomed, if I may, and we've just been learning from each other. Leo has, of course, since then moved to the US, where he now is an abdominal radiologist, and also serves as the vice chair for innovation at University Hospitals at Cleveland. He's also a professor in the biomedical department at Case Western. In radiology at Case Western as well. Yeah, so essentially he does some reporting and then lots of innovation, and he's been responsible for setting up a lab, an AI lab at UH called Radiology, where they work with AI companies all over the world, helping them with regulatory studies, what have you, and then also, they take kind of charge for getting AI into the university hospital system. So thank you, Leo, for joining. It's a pleasure and honor. And yeah, would love to
Thank you
hear
so
your
much,
journey.
Peter. And like you said, the first time we met, the way that my boss introduced me to your team was like this. Like 6 months ago, we went for a visit to India, and I met this amazing team. They had the best radiology practice in India, and we told them that AI would be the future. And now 6 months after, those guys, they come to us and they are building AI faster than we are. So they should be good. So that's how I was introduced to you.
But Leo, that is also just Romeo being Romeo. So, but no, great. So Leo, we generally start these webinars by asking our guests to uh, describe what you do as if you were telling a 5-year-old. So
Okay.
yeah, so what do you do as if you were telling a 5-year-old?
So first of all, as a radiologist, I look at the pictures from inside the body.
Ah,
And I'm specialized in very bad diseases that are very bad to people, which are called cancers, from the belly, right? From the abdomen and pelvis, especially the prostate. And my whole body of research revolves around MRI of the prostate and genitourinary imaging. But I read scans from all over the abdomen and pelvis. That's my clinical part. But then, like you said, as part of my development at DASA prior to joining UH, and also based on the needs and the strategic planning of my current institution, I was offered to join here as Vice Chair of Innovation to help leverage our programs in collaboration with emerging startups, companies, research projects that could leverage on our data and on the expertise of our clinical champions in getting any AI applications to the next level, be it regulatory approval, de-risking, go-to-market approach, business models, meaningful use, integration as a service, and so many different use cases that we can explore. And very importantly, I was very privileged at DASA to work with a whole swath of people on the corporate side that were AI engineers, AI developers, just like the ones that you have on your team. And when I joined UH, we are a clinical and research radiology department on the hospital side. And we do have very capable people on the university side, but those are two affiliate institutions. They are not one and the same. There are rules for collaboration or not. So we thought that the current capabilities we had in our department, the clinical department, they would not allow us to immediately step up to the developing game. So we thought that in terms of priority, right, to put our attention on in building an AI strategy, it would be much more effective if we focus on what we already had. And what we already had at the time was a lot of expertise from all of the stars in radiology that we have in different subspecialties in our department, but also the very diverse and robust data sets that we can combine from more than 18 hospitals that serve a very diverse region of Northeast Ohio.
so that's super interesting. So essentially, you are like somewhat of a AI engine, right, of sorts that is that is using all the capabilities across UH, the enterprise, and offering that to AI companies, correct?
Yes, we are an important cog in the whole engine
Hmm.
of AI development. Like I
Right.
said, we are not yet capable and able to do an end-to-end development of something, but I believe that we are in a very special and unique position to combine very important features that are needed in any AI development pathway,
Got it.
which is, again, the kind of data that we can leverage and the expertise in getting that data, right? Because it's not that we are dumping exams and you figure for yourself what it is that you're going to use. We got to a point that we can deliver bespoke data that is selected, that is adequate for the study that you need to carry for your regulatory needs, for your proof of concept needs. And we can also have the people that are able to act upon it.
Nice. That's awesome. So, Leo, we already have some enthusiastic folks with a question. This is, what are the different AI algorithms that you've been working with at UH?
Oh, so that's also important to contextualize, right? My role in innovation goes all the way to the frontier with clinical practice,
Mm-hmm.
which means that I cannot go ahead and push any algorithms for clinical practice that the clinical divisions or the clinical leaders were not willing to incorporate.
Mm-hmm.
So my mission here is to test, to validate, to interact with whatever opportunities we come across, and then we present and we share our results with the people who would be willing to use it or not in the clinical practice, and they do it or not, right? So, and some of those initiatives, they also come from different sources, not necessarily through me, because like I said, I represent the whole department, and we have individuals who are equally or even more successful in establishing their relationships with the industry too in our department, which I'm very grateful for having them as partners. So I can cite at some of the examples, an initiative that even preceded my arrival to UH, led by Dr. Amit Gupta in the cardiothoracic division, Beverly Rossip, our director of IT, and Dr. Jennifer Sommer, our vice chair of IT. They were able to integrate an algorithm from GE that lived on a portable scanner that was
Mm-hmm.
aimed to detecting pneumothoraxes, but they took the algorithm that was stuck in the scanner to have their messages and their information sent to PACS for better prioritization of the work list. So it was a whole project that was very successful and that's still ongoing. And they are now incorporating more and more algorithms such as endotracheal tube placement and other devices. And now they're even going into the pediatric population. So that's, like I said, something that is happening in the department and is a part of the overall AI strategy that has been happening since before. And then when I arrived to UH, one of the first opportunities, the very first opportunities that we had to interact with the industry was with AZMed, which is a startup from France that was doing very well in Europe, but they needed a partner in the US to go for their FDA filing. And we were able to get together the data that they needed, the numbers of readers with different levels of expertise, with different subspecialties that they needed, and we carried with the multi-reader study that they needed, and they got their FDA clearance based on this participation. And the nice part of it is that afterwards, the musculoskeletal radiologist, who Dr. Navid Faraji, who was leading this initiative, they saw the opportunity of implementing AZMed to clinical practice, and it has been used so far. And that was one of the examples that was implemented through CARPL. And now we are using even more additional AI applications. As you probably know, we are now running a pilot with AI Doc as another platform, which doesn't mean that we believe in any exclusivity of AI routes for implementation. This is another type of platform that we want to use. And the cardiothoracic division has been using others such as Riverrain, and they have helped in validating and approving on FDA an algorithm for calcium score estimation from screening lung CTs. And we are in the abdominal division. We are also on the route to have another one that will have to do with bone mass and body composition.
Interesting. So, Leo, you mentioned essentially there's pneumothorax, there's lung nodules, there's coronary artery calcification, fracture, and bone density, right? Uh,
Right.
do you have a mechanism whereby someone is looking at, say, organization level and trying to see like what is the benefit of like these five AIs put together? Like, does that happen right now, or do you think that is an opportunity?
That's the billion-dollar question, right?
Mm,
We just came back from SIM, and we were together there in an amazing time together and with other friends. And my takeaway from SIM and please correct me if I'm wrong and feel free to disagree, but I felt that it was my first time there. And I felt like an outsider because I see myself more as an abdominal radiologist than an informaticist, right? And the things I do in innovation are kind of in between. So it was very interesting to have that outside observation. And I felt that most of the legacy IT applications or the traditional IT applications such as PACS, RIS, dictation softwares, reconstruction softwares, there's already some common knowledge, some established and good practices that people preach together. And there's not too much variation on the way to present and on the way to approach them. Whereas I had the feeling that the AI world is still like the Wild West in which everybody's doing their own recipe. You know, we had 6 or 7 different sessions there from different institutions on how do I implement AI clinically in my institution. And every one of them had a secret sauce. No, we have this guy who sits there. We have this duct tape here that allows us to MacGyver that process. And so there was no accepted and scalable and immediately implantable way to analyze clinical AI, and that would work in 80-90% of the settings. So one thing that we liked very much was a presentation from UT Southwestern, and one member of their team was showing the dashboard that he developed that oversaw all the AI applications they had in place there. And it oversaw not only from the financial standpoint, but from the uptime. And they were also incorporating some information related to accuracy and performance. So what I would say is that we don't have it ready, but this is something that that I believe that the market is going to evolve towards. Is like a one joint view of whatever AI that you're doing in your practice.
Yeah, I understand, Leo. In fact, the way at least I think of it, the world is still divided on should there be PACS-driven work list or risk-driven work list? Do you use one risk PACS or do you use like what is now being called deconstructed PACS and stuff like that? So I think there will maybe never be one size fits all, but yes, there should be like a small, medium, large, right? There can't be. so.
Yeah.
I think that's a good segue, Leo, into Sarthi's question. Sarthi as well. Where he essentially is asking, do you see a delta in the clinical needs versus the AI solutions that are available? Or are we already at a point where the needs are directing AI development? So do you think AI being built today is being built because it can be built, or is it being built to solve a problem?
That's an amazing question too. I would say that for some indications that speak to safety and timeliness, such as brain bleed, stroke, pulmonary embolism, and things that are very tricky and that may lead to catastrophic consequences, I think that AI is a great safety net to have. Maybe for breast imaging too. I haven't evaluated any of them, but maybe for breast imaging too. So again, for any of those tasks that need you to be fully attentive, fully awake, fully on point, and you can have that friend that is always awake and always working, I think that there's already some need for AI. Subject to discussions, of course, on accuracy, false positive, false negatives, burnout, whatever, right? But in terms of need, what I definitely need, think that we do not need at this moment, and that's the point that I always try to make, is that people spend their time thinking about AI that does the very high cognitive decisions that are not timely, such as prediction of response to therapy of complex cancers combining multiple factors. Before, I don't think it will be needed. It will, but before we get to solve other more prevalent issues, which have to do with burnout, with numbers of clicks that we need to do, with rework, with processes that are piling up. So I always have this analogy that if I were to choose to buy a robot for my home, I would 1,000 times choose to buy a dishwasher robot, a vacuum robot, than a parenting robot. right? So if the industry solves the things that give us burnout, that takes us to the bottom of our license and gets us the chance to operate at the top of our license, I think this is the immediate way to go. So examples for me, for my practice, for example, I would love to have the prostate already measured on an MRI and the measurements of the prostate already input, the PSA levels of the patient already input in the report. Because then I can spend my 15 minutes, 20 minutes, or how many minutes I have to spend on that case looking at the cancer. I don't want AI to pinpoint the cancer and then still have me fill in everything that needs to be filled in and checking everything that needs to be checked. I don't want to be a bureaucratic server. I prefer to be the cognitive server.
Yeah. No, I think that is a very insightful way to put it, that you want AI to do things that are at the bottom of the license. And of course the robot analogy is pretty cool. I think that's something that, because it's interesting, Leo, there are still AI companies. In fact, I think AI companies today are being built at a faster pace than ever before, because it's just becoming easier and easier to build AI. So these nuggets of insights are that much more relevant today than they were maybe 3-4 years ago, when like the first wave of AI was kind of hitting us. So thank you for that. The next question, a bunch of people who don't want to tell us who they are. Uh, the next is, as someone who sees the clinical performance of AI solutions in real time, have you come across solutions that do not provide significant results but are really interesting? And that's also a good question.
Yes, so that's another point I wanted to make.
A really cool, useless thing.
No, but there is, I will give you an example. So we are using some solutions that do not speak directly to my specialty, right? So let's say incidental pulmonary embolism, right? And I read abdominal scans. But again, what do I care about the chest when I'm reading abdominal scans? So the fact that the solution is giving me notifications that or an output that those cases are negative for pulmonary embolism, that relieves me of the burden of looking actively for this in every single case, right? I still have to check it. I still have to read. That's still in my checklist, but with much less level of stress than if I hadn't had the aid of that AI. So the point I wanted to make with this is that a negative result most of the time doesn't mean that the AI is useless. It can also mean that, well, I'm checking this for you. You don't need to waste too much of your time, and then you can again go back and look at the things that they are actively asking you, right? But in terms of like unusual use cases, we haven't experienced them as much because, like I said, we don't let anything that is not clinically needed go to clinical practice.
I see. No, I think that's very insightful, and especially this point around, and we've also talked about it, right? That how do you, like, there might be a great insight on a scan, especially on the incidental side, but if the scan is meant for an abdominal indication and you are an abdominal radiologist, how do you even, do you notify the interventionist or the pulmonologist, or how does that work? So that's a pretty cool thing for folks to think about. Next is, what strategy do you use for monitoring the performance of these algorithms
But
that
Vidur,
you've been using?
let me just pick up this last comment that you made because it's critical, right?
Yeah.
Do you notify, right? So that's another very important point to make. Some companies are building their whole portfolio, their whole spiel around the fact that they dominate a chain of communication of findings. And the AI is just a minor part of that chain, which is the automated detection of something. But the key component will be the communication, will be the notification, right? And they claim that they bypass the radiologist or that they make things faster. And many institutions are not even measuring if the time the radiologist takes to read and notify a finding is the critical point on their delay to care. in some instances, it's the transport that is taking the patient from one facility to the other that is taking their time. So
Yes.
users need to be very careful when they hear those sales pitches that AI might be only a small component in things that include timestamps that are much more critical than the AI part itself. So as radiologists and as important stakeholders in those conversations, it's important that we rise up to those discussions and we tell, first of all, let's measure how much time we're wasting in all the chain before putting the blame on the radiologist read.
Interesting. No, that is pretty cool, especially the point around patient transport just causing a delay and not actually anything else. Cool. The next is, how do you monitor the performance of the AI that you use today? Do you monitor the performance of the AI you use today?
So the individual algorithms that we have implemented, they are monitored by the people who were responsible for implementing them, because that's part of their own research projects. And it's not yet a departmental measurement that we get. But now that we are using AI Doc, we have started to look into it more seriously. We are not that much time yet of users, but this is something that we're starting to look at, and we will have at some point something more formalized. But we don't have anything as a policy or as a dashboard yet that I can rely on.
Got it. Because as you know, Leo, we work with the Singapore government, and there, they've actually come up with guidelines for monitoring of AI solutions in clinical practice. So, maybe we'll share those with you. They're pretty cool the way they're approaching it and or making it almost mandatory. We'll run through these questions because we have only a couple of minutes left, and we try to end on time, Leo, to be respectful to everybody's time. We do, for everyone's sake, post the questions that are left over on our LinkedIn page, so so you can get those. What are results that you can share with us on application of AI with radiology? I don't exactly know what that means.
Well, I'll try to answer as best as I can. So we have some published results on pneumothorax detection and on fracture detection. They are available if you look for not necessarily my name only, but of my colleagues too, whom I mentioned. You'll find their recent publications on the results. I can say that pneumothorax has significantly decreased the time to read an exam that is positive for pneumothorax on non-stat exams. So that's very important, because you prioritize patients that would be left for the routine work list, and they were pulled up to be read first, and that was significant and well measured. For fracture detection, the main results were that emergency doctors and non-specialized radiologists got to read at the same specificity level as that of fellowship-trained, board-certified musculoskeletal radiologists, and everybody got their reading time reduced by 20% on average. That's on the study, right? But then as a user of a new platform, right, that we have implemented, I don't have any scientific data to share yet, but as a user, what I can say is that it is very satisfying to me to have the safety net that I can click on any exam, and it tells me already the things that the patient doesn't have among things that I wouldn't be interested in looking for.
No, that's pretty cool. Leo, as we wrap up, last question from my side, as a radiologist who moved, from Brazil to the US, now spending most of your time on innovation and AI, what are some words of wisdom for young radiologists who are looking at emulating your journey, either moving from, the developing world, say Brazil, India, Southeast Asia, etc., to the US, or just thinking about entering this field of AI? Any final words of wisdom?
Thank you for this question. I don't know if it's wisdom or not, but it's something that I did my whole life. Is that, and it's something very common on the Z generation, to be very living the minute and looking for immediate rewards. What does it get me now? What does it get me today? I think that this mindset doesn't play well for you to position yourself for amazing opportunities in your future. So what I would say is that if you have the chance to invest in even earning less or working more, but you play the long game in developing additional skills that are not immediate for what you have to do today, but they can be useful if you would have the right connections or the serendipity of being in a situation where you were the only person who were able to get there, because again, nobody was investing in it at the time and you did, right? So for whoever is starting their careers, if they could resist that urge to go for the shortcuts, to go for the immediate money, for the easy work, for, oh, I only want quality of life. Quality of life is very important, of course, right? But you can't only want that, because then you're going to be complaining at some point that opportunities are not coming your way. So you got to be open for the opportunities to come, and that's by being prepared.
That is awesome. So we'll end on that note. Think long term, don't think short term, and enter our field. You know, it's a beautiful, beautiful opportunity to change the world. So thank you so much, Leo. Thank you for being a friend, being a user, being a customer. It's
Thank you.
always amazing to talk with you.
Thank
Thank
you
you
so
so
much.
much.